Everywhere I turn, I am seeing physicians wanting to find a way out of medicine, wanting to leave the bedside. And that really concerns me, and that should really concern everybody.
71,000 physicians left medicine in 2021-2022. What's more, surveys suggest that this trend is particularly apparent amongst younger physicians just starting out. More than half of medical students don't want to practice medicine as their career. This should alarm us all. Graham Walker, you are an emergency medicine physician, innovator, visionary. Why OffCall?
I think that the focus is really around my concern, my societal worry about everywhere I turn, I am seeing physicians wanting to find a way out of medicine, wanting to leave the bedside. And that really concerns me, and that should really concern everybody. Not only in the way that we need people who have, you can't just churn out another physician in a week or a month or a year. It takes a decade or more to turn a human into a physician. And so, we lost a lot of physicians during COVID from both retirement and death, honestly, and disability. And so we're losing physicians that way. The physicians that are coming on board often are, within the first few years of being an attending, are often figuring out, how can I get out, or how can I do something else? And we are now seeing that there are other parts of society that are valuing a trained physician and will hire them, maybe not for the exact same amount of money as it would be to practice medicine, but a relatively competitive salary or amount of money, certainly in the technology space, to bring on a physician. And so physicians are now seeing there are alternatives to just practicing medicine. And we need to make practicing medicine the most competitive place for a human that decides to become a physician to stay at the bedside.
Say a little bit more about the mission of OffCall and what it actually does as a platform.
So we want OffCall to be a place where physicians are valued and where we are creating tools that help physicians. We want to start out by building tools and information for physicians around job transparency. So that's certainly including salary, but that also includes all the other stuff, Resa, that makes our jobs great or terrible at the end of the day. It is it's not just the number of the dollars and cents that you make per month or week or year. It is, how many patients do you see per day? Do I supervise nurse practitioners? How many patients do I see per hour as like an ER metric? If I'm a cardiologist, how many echoes do I read per day? Do I have a good relationship with administration? What EHR do I use? Do I have an AI scribe that helps me get through my day? All this stuff is like the 1,000 little paper cuts that make a job great or terrible, and that data doesn't exist right now. So we want to provide that to physicians. And then we also want to work on providing that community space and some education for physicians, specifically around finance, but also other areas of medicine that are not really well documented or clearly explained to physicians about how to have a practice that exists for 30 plus years.
I think this circles back to your concern about medicine becoming a more lonely place, that it is actually now a more lonely place, and how to reconnect and realize the support and the network that is, specifically in this case, amongst physicians. When we look at where you grew up, suburban Kansas City, father's a psychiatrist, mother was a psych nurse, as well as a dental hygienist and other things, Hallmark cards you mentioned.
Yeah.
What's one thing that you learned from growing up in the suburbs of Kansas City, and the fact that you loved making visits with your father to CompUSA?
No. I mean, calling out CompUSA, hashtag CompUSA stan, certainly the technology piece I learned from my father. He's the reason that I'm into tech. We had an Apple IIe and then a Compact 286. And I remember going to probably CompUSA and getting a Intel inside Pentium processor 486. And it was a really big deal. So certainly that technology all comes from my dad, and he's still super active and passionate about kind of technology and gadgets and stuff too. And then I guess I would just say, you know, I definitely felt like I wanted to get out of Kansas. Looking back as now an adult, I Kansas and Overland Park, the suburbs where I'm from, it was a really I was very fortunate to grow up there. It had great public schools and it was safe and was able to, set me on the track that I am today. My biggest challenge with Kansas City, and it's become a lot more diverse now, is just how white and conservative it was. It's, growing up in the 80s as a closeted gay kid certainly made me want to escape Kansas City and find a more diverse place um, to sow my oats, my wild oats. So, I moved to Chicago to Northwestern in college, and that was the one thing that I wish I had more exposure to diversity in Kansas City. But it's a trade off, right? It's like everything in life.
Was there a psychiatry, mental health thread that supported you through childhood and teenage years?
I mean, I'm sure the way that my parents approached being parents was highly influenced by the fact that they were in the mental health field. People used to always joke that like my dad was, "Oh, your dad's analyzing me or something," and I don't know that he was. I think he's just also even more introverted than me. I'm like a mixture of my parents. My mom's much more extroverted, and so I'm sure the way my dad would approach things was certainly influenced by not just psychiatry, but just being a doctor. The old trope of like doctors' kids are really have to be extremely sick to like not go to school. It's like, oh, you have a cold. Yeah, I don't care. You're going to school because we have a different thermostat of what an ill person is, kind of.
You shared that you moved to Chicago, you attended Northwestern, and you were a social policy major. What is that?
So social policy is like like a public policy or a health policy degree. That's just what we call it at Northwestern. I was really interested in psychology and sociology as an undergrad, and then but it didn't like have the hook of like, okay, these are interesting academic concepts, but like, how do you make change or how does that get implemented? And I was like, oh wait, there's this thing called social policy that I learned about, and it's a major, and it's in the School of Education. So I changed from the School of, I think, sciences or whatever it was called, to the School of Education and Social Policy, and took fantastic courses on just how do you set laws and policies and what are unintended consequences that have happened and what's the current, my focus was on healthcare policy. What is the current policies of the United States in terms of health? What are the impacts of those? What has worked? What has failed? Why have they failed? Really thinking about how do you make change in a effective way that does the most good for the most people.
Yeah. It's interesting. We're building up all the bricks in your foundation to where you are today. You had a job after college in a startup, a single payer insurance startup. And simultaneously, to make money to support yourself, you started building websites. One was for repertory theater companies.
So yeah, I knew I wanted to take a year off after college before medical school. I knew I wanted to go to medical school, but I had lived in the dorms all 4 years, and so I wanted to like have a year where I was like living in an apartment. And so yeah, I moved to downtown Chicago and worked for Physicians for a National Health Program. They're a nonprofit and the the only organization that's nationally working toward single payer health insurance, like a Medicare for all, essentially is the way that we try to brand it now these days. And yeah, I had taught myself web design in high school, and then I had made some web pages for during college. I made the first my Northwestern's theater group, improv group is called Meow, and so I made Meow's first web page ever. And yeah, so I would make little websites for people on the side just to make some extra cash because I think, you know, PNHP, the nonprofit, I think I was making, I think it was like maybe $23,000 a year. That was in 2002. So yeah, just a little cash to pay the bills.
You sashayed to Stanford, where you were a med student and continued with building. This is the origin, 2005, of MDCalc. And you famously talk about the ransom criteria. You were asked to state the ransom criteria, and you thought, why would I memorize that? That's not a good use of my brain time.
Yeah.
And so you started MDCalc. For the audience members that aren't familiar, what is MDCalc?
MDCalc is a free medical calculator tool. We're used by about two-thirds of US doctors. It's a website, it's an app. We have an EHR integration now as well. And it allows doctors to answer a question they have using evidence. So, Risa, if you come to the ER with pneumonia, I could use some things about your vital signs, your age, your risk factors, and then kind of help me get a recommendation. If I'm not sure what to do, help me get a recommendation about, oh, should I send Risa home with antibiotics, or should I maybe think about keeping Risa in the hospital?
It's a beautiful tool, and there are about 800 to 900 scores,
Yeah. Yeah.
upwards of 1 million users per day. And this is not just physicians. You have nurses using this, you have pharmacists using this, and it's quite useful. It's free. It decompresses that cognitive load of memorizing. Say a little bit more, the EHR integration.
So, part of MDCalc is often taking data either from the patient's medical history or from the electronic health record, say your oxygen saturation or your white blood cell count, and then inputting that information into MDCalc. You either pull it out on your phone or open the website, mdcalc.com, and the EHR integration just removes that step. It is able to pull the data directly from the EHR and insert it into the kind of calculator score to make it simpler and also safer. Sometimes you can imagine people have a typo or they add a zero or they fat finger something. And so, it adds a level of safety. And then it also is able to take that, take the result of the calculator and file it back into the EHR, so it's also one less step for the doctor to do. That information gets saved into the chart, and the doctor can move on with their day.
It's very character consistent because you have said about yourself, inefficiency bothers me, and you like to get rid of hurdles.
Yeah, and inefficiency drives me totally insane that I will spend way more time. If something takes me an extra 3 seconds, I will easily spend hours to just get rid of that 3-second thing. It almost doesn't seem like it's a wise investment of my time, but it gets under my skin. It gets stuck in my brain, and I'm like, there's got to be a better way to do this. I mean, that's literally why I made MDCalc, and most of the other things I build is I'm actually building it for myself because it just bugs me. It just gets under my skin, and so I will uh, you know, build a little website or build a little tool that makes this thing that takes either too much time or it's too complex and tries to boil it down to its essence or down to a level that's way more easy for a human to get through and handle.
From med school, you moved to New York City to residency. We know it as St. Luke's Roosevelt. It's now part of the Mount Sinai system with some other names. And you were full on with MD Calc, building, growing it, and then another productivity tool, user friendly for healthcare workers, NNT. Can you just give us a one liner about what is the NNT?
The NNT, the term, is an evidence based medicine term. And the idea is it is a way to compare interventions in medicine. So you could compare one drug to another. And the idea is stands for the number needed to treat. So, Risa, if you have antibiotics or if you have pneumonia and I want to give you antibiotics, the NNT for antibiotics might be 10 or 20 or 50. That means that I would have to give antibiotics 10 or 20 times to help one of those people. When you learn that in medicine, it seems not possible. It seems like, oh, you have a bacterial pneumonia infection. Every single person that gets antibiotics is going to get better. Or the same with, like, we all hear about aspirin for heart attacks or aspirin for strokes. You think, oh, aspirin saves a life when you give it for a heart attack. And it does, but it doesn't save every single life. medicine and life is just so complex and complicated that you actually have to give, statistically speaking, aspirin or antibiotics, whatever it is, to numerous people in order to actually help one single person.
Yeah.
And so that's the evidence based medicine term. And in residency, we then created a website called thennt.com and tried to take really expansive, comprehensive reports called systematic reviews that are often 90, 100, 150 pages long and distill them down into bite-sized nuggets of information that a physician could then easily use to practice better medicine because they knew this tool was useful or this drug was helpful or not helpful. And we kind of gave it a traffic light. Green, this is things awesome. Yellow, hey, it could be good. Red, hey, this is actually probably harmful. And black is like, hey, this is absolutely harmful. You should not be doing this.
Yeah. It's actually a really beautiful healthcare design tool, and it's to allow us to provide safer, better, patient centered care.
I think the very best one we have on the site, and I think the one that's the very best in all of healthcare is defibrillation for cardiac arrest due to ventricular fibrillation or ventricular tachycardia. So that's when somebody's heart stops, and if they have a rhythm that can be shocked back to life, um, I think the NNT is like 2 or 3, 2.5, something like that for that. So if you do that in a short period of time, you only have to do that like twice and you save one of the two people's lives. So I think that's the very best, the lowest NNT. You only need to do it to two people.
Simply stated, electricity placed on the chest to shock them when the rhythm says EFib or VTAC. Residency ended as it had to. And when you graduated, you were a chief resident, already exercising your leadership skills. You went to Stanford and completed a simulation fellowship, quickly moved to upon completing fellowship, your first job at the
Yeah.
Permanente Group. You've now attended many, many meetings. You've been in many, many meetings. You have led many, many meetings. What would be your top pearl for how to run a good meeting?
I will, I'll call back to my efficiency piece. Um, never have a meeting that could be an email. So like, could we just eliminate this meeting entirely? And sometimes that's possible and sometimes it's not. Certainly having an agenda for the meeting to know why are we doing this? What do we hope to get out of this conversation that we're about to have? And I think then I guess I would just say having everybody be punctual and ending the meeting on time as well. I think we as a society have all gotten more okay with everybody can be a couple minutes late. Um, and then other meetings run over by a few minutes. But I don't love that, and I also, one example that I've seen that if you make a meeting on Google Calendar now, the meetings the meetings I think are 25 or 50 minutes. I think that's the default. You can set it to 9 to 9:30, but I think the meeting, if like a 30-minute meeting ends at 9:25 by default, and I love that because meetings will fill up the volume of time that you've allotted for them, and I love the idea of giving humans a break in between the meetings, and it also pads the meeting. If the meeting does need to go over, you're not then running into the next meeting being delayed or something like that. So I love that little default, little nudge behavior that hopefully makes things a little bit more palatable.
How do you think your colleagues would describe you as a leader?
That's such a great question. I think they would describe me as passionate and energized, and uh, certainly I use humor, like probably too much humor, and then I guess I would say authentic. I think I try to be very authentic, and I try not to pull punches. I mean, I'm not like a rude dude, but I try to be honest when I think something is going to work, or I disagree, or I'm always like going back to that social policy brain of, well, if we do this, that's going to break this other thing. I'm always thinking about unintended consequences. I'm always thinking about what what will be really good about this new regulation or policy, and then I'm also thinking about like, oh gosh, this is going to suck for these other reasons. And can we find like an in between solution that like, dials up the good and dials down the bad as well?
Yeah. I asked you about leadership because now you've had so many stages and experiences that supervisor supervisors, you've had leaders. What would be one positive leadership tip you learned? You don't have to name names or institutions. And what was really something that was amazingly educational, but it was a horrible experience with a supervisor or a leader?
Okay, I'll do the positive one first. And I will name names. I mean, I say this all the time, but our CEO, Dr. Maria Ansari, and this sounds like so kiss ass, but she is just freaking amazing. And she is incredible at like getting her leaders to like kind of operate at their highest level and let them be as efficient as possible. Because I think part of I think the way she thinks about it is like, how can I clear the way? How can I clear roadblocks and hurdles to like bring everybody else up a notch? Oh, this is a problem. Well, let me talk to that person so we can get it taken care of. Oh, you know, every time she used to be my local boss. She used to run the Kaiser San Francisco Medical Center. So I've worked with her for probably 8 years now. Every single one-on-one we would have, she would ask, Graham, how can I help you with your job? Like I was running technology for my medical center. She would say, "How can I make you like? Hey, what do you need? What do you need from me? Oh, you want to do a contest? Okay, yeah, I can fund the contest to fund some prizes, so you can try to drive adoption of dictation tools or technology, whatever it is." She would constantly say, "How can I help you be the most effective leader you can be?" Essentially, so I absolutely learned that from her, and that I try to do that with people in the groups that I lead as well. I think I will not name names, and I can't honestly think of a specific individual for the negative example. But what often comes up in healthcare is what my friend Corinne McCleary calls the "they" problem, and it is that there is some rule or regulation or policy that is often not like clearly spelled out. That is just like um, somebody says you have to do it this way. And then when you try to dig into, well, why? That doesn't make any sense. Why would we do that this way in the ER? Well, they said you have to. And it's usually actually that word, THEY. It's usually not an actual human. It's not, it's a nebulous they. And so it almost like fully shuts down discussion.
Can you give a specific example?
So sometimes there are forms you have to fill out in order to get your patient to the next step in the process. You need to help get them to a custodial skilled nursing facility. You need to help them get to a shelter bed. You need to help them get to a dentist, whatever it is. And maybe you're told to fill out this form, but the form doesn't actually fix the problem. But the system has decided that nothing's going to get done until this form is filled out. But you don't, again, it's a nebulous requirement that somebody told you have to do, but there's no way to like fight the system almost, or question the system, or come up with probably the reason it frustrates me so much is it's inefficient and I cannot fix it. It's like the system has decided.
And is the negative aspect slash amazing feedback as a leader that someone needs to take responsibility or someone hasn't noticed the
Oh,
inefficiency and removed it? Like, what about it is the lesson regarding negative leadership?
yeah, thanks. I didn't get to that. The negative leadership is that the person making the decision is so many levels detached from the person doing the work.
Mm.
And it is very clear that the person making the decision has no connection to the work that they are dictating and mandating somebody else do. So that's the piece is understanding and respecting and being beholden to the frontline workers, particularly in healthcare, that are doing the work and understanding that your rules are going to have consequences for people and make people's lives worse who are already having a rough time, if that makes sense.
It makes sense, and I'm gonna tie into more quoting Graham Walker to Graham Walker. You can never over communicate a change being made in technology, and
I
that you
I
have
love
to
this guy. Who is this guy's freaking brilliant.
Yeah, he's pretty visionary, pretty visionary.
Yes,
Reminding
that
people how far we've come because they will complain. They will find and always be looking for and looking at the next annoyance. So you can never over communicate enough because people will say, I wasn't told this. I didn't, no one told me that. Wait a minute, what are we doing? Say more about this, and I'll tell you why this lesson in healthcare resonates so much with me.
sure. It is really hard, and I think it's because physicians are busy. It's not that physicians are obviously dumb or bad people, or it is because physicians are so busy all day taking care of patients that communications at a my communications were typically around technology and changes to the EHR, for example. Those communications often got missed by a small minority of physicians. And so I would go out of my way to communicate it multiple ways and disseminate the information as many times and as many media as possible. Because look, I get it. People are just busy and nobody wants at the end of a long day to read another Graham email that he's maybe sending. And so I think that's the reason that you cannot over communicate things is honestly, it's just that healthcare workers are just busy people delivering care. And it's not like we're sitting in an office all day. And part of our job is to normally just read our emails as part of our daily work. Most of our job is just like seeing patients.
I learned in the point of care ultrasound world, building workflows, educating, QA, all the steps. You live in it, you speak the language. It's no big deal when there are updates, when there are changes. But for people that aren't living, speaking ultrasound all the time and looking at these workflows, it's one more thing, one more
Yeah.
ask, one more task. And so the smallest change is actually overwhelming, and people are still integrating the change and the update that you shared 6 months ago. And so what I learned was sort of the judicious number and frequency of changes and updates to the workflow.
You hit on a really big point, Risa. The capacity that many people have to tolerate change, I think, has gone down. And then additionally, that's also why it's so critical that you get the decision right the first time or get the whatever it is, the system, the policy, the whatever, the first time, because it is so hard to make changes in healthcare for many, many reasons. So that's why it's really important that you get it right the first time. Is that the change management is way harder than any new technology integration, any new, it's just the change management is the hardest part by far. I would
Yeah.
take anything besides doing change management in healthcare.
And this goes back to why I deeply believe that you are a healthcare designer. I am a healthcare designer. It's that iteration, poke holes, brainstorm, whiteboard, do it all up front, iterate, bring many, many users, definitely the end user, be that the patient, be that the caretaker, be that the clinician, to the table, iterate, so that when you spit it out and it's go live, it may not be perfect, but it's going to be so much better than had you not done those exercises.
Yeah, and there's not like I have not found with my in my efficiency brain, I have not found a better, more efficient way to do this besides just like show it to a lot of people. In the technology space, you can build out these whole we call them like testing suites. So you can build out you can build write code And then you can build out a whole testing suite that says, okay, if you click this button, the the text should turn red every single time. And you can build out the tools to then test your code so that if you make a change to the button, it doesn't break the thing that makes it turn red. You can't do that in healthcare. There are so many human beings that use the electronic health record in so many different ways that the only way that I've really found to do this is just show it and to a lot of people and ask a lot of specialists. I sit on our EHR steering committee, and that's the reason we have representation from pharmacy, from nursing, from eh, I think probably like 80% of medical specialties, because it's just critical that you have as many people with eyeballs on this thing and looking at it and then testing it as well to make sure it doesn't break like the nuanced thing that the anesthesiologist does that has literally nothing to do with what I do as an ER doctor.
Yeah. And I'm going to tie this into off call. There is a stat from the website. 50.4% of physicians reported feeling valued in 2023. And that was up 4%. In
Yeah.
2022, 46%, which I don't think this is a great statistic. To be up, that's great. 2022 to 2023, we went from 46.3% to 50.4%. We're up a little bit, but still only 50% of physicians feel valued in today's healthcare system.
Growth mindset. Yeah, we're up. But I think the challenge is that medicine has become very corporatized. You know, the other statistics from off call is that 80% of us are employed by somebody else. Often our boss is not a physician. I'm very fortunate that all my bosses are physicians, but often in the United States, the boss is not the physician. And so medicine has become very much like a profit seeking entity. And so it's hard to feel valued if you are viewed as just a widget producer or just your expectation is just to churn through patients constantly, day in and day out, and to also have your autonomy reduced. That y all of this 10, 15, 20 years of training that you've received leading up to becoming an attending physician feels devalued in that you just need to do what you're told is kind of the message that a lot of physicians get, and not do a nuanced, individualized care plan for an individualized patient, which is the kind of way that medicine is taught, but you need to get in line and do things the way and be standardized with how everybody else is doing things for efficiency reasons when we know that each patient is unique and different and standardization and customization are always going to have friction in healthcare.
I'm going to make another thread through the life of Graham Walker. There's social policy. There
Yep,
was the blog that you wrote as an early adopter of medical blogs called Over My Med Body, which is
that's
such a
right.
beautiful title, to the Physician's Charter. Tell the audience, please, about your blog and about the very prescient, very important Physician's Charter. And I
So
wanted to use the word prescient right there.
so nowadays blogs are everywhere, but back in 2003 when I started the blog, it was a web blog. That's where the term comes from, a web blog. And there were a small number of us physicians, many of whom I'm still close friends with today, that were blogging, that were talking about their experiences as a doctor, as a nurse. We called it the med blogosphere. This was before Twitter and this was before social media and iPhones, and we were just finding ways to connect and share our experience. And I had decided, yeah, I want to blog my way through med school. I want to explain what it's like going from a just human that's interested in medicine to like an actual trained human in medicine, what the difference is between those two people. And there were other physicians blogging about being a surgeon or a pediatrician, and so we would connect with each other and talk because again, this was before social media. There weren't We would comment on each other's blogs as a way to communicate with each other. And, fast forward many years later, decided to create this thing called the Physician's Charter for Responsible AI. I think certainly the thread around this is I enjoy writing a lot. It helps my brain understand the world and it makes my own beliefs and ideas clear because I have to put them out on paper for somebody else to read as well. The Physician's Charter was inspired, honestly, by ChatGPT when it hit the scene in 2022 in November. I think, about 2 years ago now. I immediately was like, oh crap, this thing is going to take over the world immediately. Now, obviously, it hasn't 2 years later, but I do think it's changed the world. And I strongly felt like it was going to take over everything. And I felt like physicians, AKA myself, like needed to like plant our stake in the ground. Like I felt like we needed to say, hey, here, we need to like, hold the line or say, no, ChatGPT, we're not going to have doctors, we're not going to have ChatGPT take over medicine. I'm sure part of it is like a bit protectionist. I think that's probably the biggest criticism people would have. Oh, doctors just trying to like control medicine and it's paternalistic. But really, I mean, in my hope of hopes, it was that I didn't want patient care to be degraded. And I think patients deserve to have a well trained human help them with their lives and their medical problems. And I was really worried that ChatGPT would just take over and would cause harm. That's really where I worried. We've all seen how Dr. Google can be very incorrect. And I was very worried that patients would be led astray and there'd be harm caused to people who just didn't know any better if ChatGPT took over. And so myself and 10 other physicians, we all found each other on LinkedIn and decided, hey, let's like write this charter about how we would want AI to work in healthcare if we were in charge.
What's been its reception?
It's been really positive. There are a lot of organizations that are now trying to do this, which is outstanding. There's Chai, there's the AI partnership at Duke. And so there are a lot of people talking about this. So I feel way reassured that there are many physicians that are passionate about this. And it's not just like us on a little, us 10 doctors trying to figure this out. So I'm very hopeful that AI will be deployed in a way that is patient centric and keeps the physician and the patient at the center of everything. And AI can be a helper.
So, where would you say the role is for LinkedIn and for other listeners that are looking to grow their voice in that space?
Sure. Risa, when I joined LinkedIn, I hated it. It was so bad. Um, I left Twitter, where I spent a lot more of my time in 2022, because Elon took over and brought a bunch of misinformation people back on the platform. And I was like, well, I'm not going to support. I spent a lot of time during COVID fighting misinformation. And I was like, I'm not going to spend my time on this place anymore. If you're just going to have all these kind of ivermectin people on here. So I left in 2022 and then wasn't doing any social media for several months. And I was like, I was like, oh, I like writing, but I don't have a place to write. Um, and I want, and it, I wanted to share my thoughts as well. And so I was like, ah, screw it. I'll like try LinkedIn. And LinkedIn was, and I think still remains like you said, super corporate and very like superficial and fluffy. And I hope that LinkedIn has become a little bit more like Twitter and a little bit like more like me. And it's not me that's changed. But I think LinkedIn has become a better place to share your professional thoughts because everyone has their real name on there and people are generally professionals, right? I had like 25,000 followers on Twitter, but I didn't who knew how many of those were bots or how many of those were actually people that I cared about their opinions as medical professionals or technology experts or whatever. But on LinkedIn, I actually have a pretty good sense of who my followers are. And most of them are doctors, other healthcare professionals, and tech and AI people, which are the exact people I want to interact with. In that way, I think it's been fantastic. I think each follower that I have on LinkedIn is way more valuable than the ones I had on Twitter, because most of the ones on Twitter were just anonymous, and I had no idea if they were people that I cared about their opinions at all or not.
Your voice. When did you realize you had a voice, and when did you start using that voice in any way, shape, or form you want to define it?
Well, I'm a baritone, so I knew that for a long time. I think I think in my meds, I don't know if in my med school interview, I think I think in one of my med school applications, I wrote that I like had to come out as a like tech kind of nerd person before I actually could even come out as a gay man, because like at that time tech was also super not cool to do. But I was really good with tech because I grew up with it my whole life.
CompUSA.
Um, CompUS, hashtag CompUSA. And so I think part of the reason that I found my voice is because as a gay guy, I had to get comfortable with being different and being other by society. Um, and that was a hard thing to accept and learn. And like, you have to figure out how to be like, screw it, I'm just going to be who I am. I think that is actually part of the reason that I am able to have a strong, authentic voice, is because do I care what people think of me? Yeah, deep down, I secretly do. But there is absolutely part of me that had to learn the lesson that, like, you can't care what everybody thinks of you, and you have to be okay with being different. You can't, otherwise, wouldn't want to live in your own skin, like as a gay person. And obviously, being gay is and different identities are way more accepted now, but in the in the 80s and 90s in Kansas, it was not that way. Like, being gay was literally the worst thing you could be. And so when I deep down knew that, that's a really hard thing to acknowledge and admit. And that one of the ways you can finally get to self-acceptance is being like, hey, I have to be okay with being a little bit different than other people, which I'm really proud of now. It's like, makes me who I am.
The Visible Voices podcast amplifies voices in the healthcare, equity, and current trend spaces. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Find me at Resa E. Lewis MD on social media, or visit thevisiblevoicespodcast.com. Find us wherever you listen to podcasts and watch our episodes on YouTube. This podcast is for education and entertainment purposes only. The views and opinions expressed by our hosts and guests are their own and do not reflect the opinions of their institutions. Information shared here should never substitute for clinical judgment or for medical advice. Together, we're making healthcare more equitable, one visible voice at a time.